Hi, and welcome back to JAMA Network Open Live. I'm Seth Truger, Digital Media Editor, JAMA Network Open.
I'm Angel Desai, JAMA Fishbein Fellow.
Of course, if you're following along live, please send us your questions and comments on Twitter at JAMA Network Open, or you can add them in the comment section under the video on Facebook or YouTube. Apologies, both Angel and I have separate colds, so it might be a little more nasal today. But keeping with that infectious disease theme, today we're talking about adjunctive rifampin therapy for diabetic foot osteomyelitis in the Veterans Health Administration by Wilson et al. And we've got second author, Dr. Mary Bessison, with us. Welcome.
Thank you, and thank you for the opportunity to talk about this work. And I'm glad you mentioned Dr. Wilson, the first author, and Dr. Bonomo. I'd like to acknowledge all the co-authors that were critical to this work. So this was a retrospective analysis of patients treated in the Veterans Health Administration for diabetic foot osteomyelitis between 2008 and 2013. We looked at patients who received rifampin versus controls. We excluded medical centers where rifampin was not prescribed, and we found that survival and was improved, as were amputations, in the group that was treated with rifampin. Now, of course, this is retrospective work with all of the inherent biases of that, but this was gathered as pilot data in preparation for a prospective trial.
Right. Well, this is really interesting stuff. I'm an ER doc, so as I was saying, I don't prescribe a lot of rifampin in my practice, but I certainly see a lot of people with diabetes and diabetic foot osteomyelitis, and it's always good to have more arrows in the quiver for this. So tell me, where did the idea of rifampin for this come from?
Well, it came from a couple of places. There are some in vitro characteristics that make rifampin attractive. It penetrates biofilm and is active in biofilm. It penetrates osteoblasts and remains active there as well. In Europe, rifampin is commonly used for treatment of osteomyelitis, but in the United States, it has not been employed as frequently, perhaps in part because of issues with drug interactions, but mostly because the amount of clinical data available is really relatively small. It's mostly observational and some very small clinical trials. So we were interested in expanding the database.
Well, that was actually something I wanted to follow up on because, I'm as a caveat, I am an infectious disease doctor, so I loved this study for many reasons. But one of them was that, I think we're really comfortable with using rifampin in prosthetic joint or, in settings where there's hardware involved for that exact reason related to the biofilm, but I've sort of seen variable practice in terms of use of it in osteomyelitis, so I was really happy to see this study. And the one other thing I wanted to point out, which I wanted to ask about because I thought it was very interesting, was the fact that something like 32% of the cases that used rifampin did not have an infectious disease consult when they were using it. And I wondered if you had any thoughts about that or if you were surprised about that as well.
I was surprised that fewer than half of cases overall had an infectious disease consult. It was more frequent in the people who were treated with rifampin to get an ID consult that we were able to detect in the record. Of course, this is retrospective data. There's potential for us to not fully ascertain all of the infectious disease consults. But in a number of smaller VAs, they don't have access to an infectious disease consultant, at least physically on the premises. So that could be part of the issue as well.
Okay. We've got a question from one of our followers. Emily Ling asks, have they looked at effectiveness of rifampin in any of the European populations that are using it more commonly?
There are some retrospective data in European populations that show a trend towards benefit in the group treated with rifampin. Okay. And this is for diabetic foot osteo. Right. And for osteomyelitis in general, outside of the setting of the diabetic foot, there also are observational data suggesting that it may have some benefit.
Right. So, and you mentioned a number of times, I think appropriately, this is retrospective observational data, and there's some differences in the patients. So the patients tended to be a little younger, average 62 versus 65. slightly healthier with a slightly lower Charleston comorbidity score and slightly lower on some of the cardiovascular risk factors, et cetera. And again, with the difference in the ID consultation. How much of it, from what you know about the patients who've been seeing it, how much of it do you think is patient selection, where healthier patients who are less likely to, say, be on warfarin or other drugs that would interact with rifampin, versus it's the rifampin's potential effectiveness?
That's a very good point, that the populations are different, and that was part of it. We did perform a logistic regression analysis to do our best to control for those confounders. And in doing that, the difference remained statistically significant with an odds ratio of 0.65, did not cross 1. So you can never perfectly account for all potential confounders in a retrospective study, but to the best of our ability, it remains significant after doing those corrections.
Yeah. And that's great. And again, I think I always love it when authors are responsible about, not only making all the right caveats, but also you're already working on a prospective study, or prospective trial, which is what really matters. It's not just, we found this great retrospective data, which is great. So we've got a couple other people who started following. Beautiful World and Melissa Reed have joined. So welcome. We're talking about rifampin for diabetic foot osteomyelitis. What else you got?
Yeah, I had a question, and I think it's just left me, but I'll follow it up with a different question, which had to do with the characteristics of the population in terms of who had Staph aureus infection and who did not, because at least, from my experience, generally we are using rifampin in these sort of Staph aureus infections, and I just wondered if you could speak to that at all in terms of what you found in this study.
Right. So among patients who had a culture, we analyzed whether there were differences according to whether Staph aureus was isolated or not, and in fact, that did not appear to have an impact, and we were quite surprised by that. We thought that, as many people did, that Staph aureus is the main place that rifampin has benefit, but in fact, in this study, it didn't seem to have an interaction, didn't seem to make much difference.
Interesting.
Really interesting, yeah.
So we've got Nima joined us as well, and one of the limitations that you mentioned in the study is there's the potential for survivorship bias, which I believe because rifampin's relatively long-term therapy, you wanted to include patients who are comparable, who are in the study for a long enough period of time, and also that means they even if they didn't get rifampin, survive long enough to be in the study for a long enough period of time. So can you talk about that and how that may have impacted your work?
So I think what you're getting at is that we excluded patients who had an event in the first 90 days. Mm-hmm. And the reason for that was that we felt that those events were destined to happen, and that whether, independent of the treatment, and that was why we excluded them. It is a potential weakness, and again, a reason to do a prospective trial.
Yeah, absolutely. And again, I think I remember my first take when I first looked at this paper was, this is great. This is providing some good foundation for doing a prospective trial on it. So good stuff. We've also got Carlos who joined us. Welcome. Any other questions?
Yes, I remembered what I was going to ask before. Well, it was actually more just a note of appreciation for including, I think there was a sort of a 6-week window where patients within that time period, if I'm remembering that correctly, there was some time period where if patients had any sort of rifampin exposure for a certain amount of time, but also within a pre-specified time period from the sort of diagnosis were included. And I really appreciated that because I thought in some ways that was pragmatic, because I think there's also variability about when providers will start rifampin in these situations. So I just thank you, I guess is what I would say to that.
And of course, when you're using ICD-9 codes to detect your cases, that introduces a certain amount of wiggle as far as when exactly did the diagnosis happen versus when we detect the code.
Certainly.
Right. Absolutely. And I'm going to welcome also Hashem Afifi has joined us. So welcome. We're talking about diabetic foot osteomyelitis. So any final thoughts here on the paper or plans for any details you can tell us about the trial going forward?
So there are details available at clinicaltrials.gov. We anticipate enrolling 880 subjects. We're just at about 400 subjects enrolled. So it's being conducted at 28 sites across the country, and we anticipate finishing in 2021.
Great. Well, sounds good. Well, keep up the good work and look forward to seeing the future publications.
Thank you. Thanks again.
Great. Thanks. Take care. All right, Angel, what do we have next?
Okay. So first up, we have, let me just get my papers in order here. First up, we have Association of Receipt of Positron Emission Tomography Computed Tomography with Non-Small Cell Lung Cancer Mortality in the Veterans Affairs Healthcare System. So this was a study that was trying to look at the association of using PET-CT with non-small cell lung cancer mortality. Very interesting. Also using VA data. Was looking from 2000 to 2013. And essentially what they looked at were which patients that had non-small cell lung cancer got a PET-CT, and then they kind of looked at some more granular data. So overall, about 80% or 81% of all patients with this diagnosis had a PET-CT. 40% of patients 40% of patients that had a PET-CT had it within the 12 months prior to diagnosis. 64% of patients had it within 5 years after the diagnosis. And what they found is that over time, more patients are getting PET-CTs with non-small cell lung cancer. And this was very interestingly associated with a higher level of complexity in the patient, but then also sort of looking at VA facilities as well. So things like looking at, which VAs have availability of PET, things like of that nature. They found that certainly in VAs that have more capacities, there was actually a mortality benefit to using PET, which was interesting. And then they also found that over time that there was a decrease actually in non-small cell lung cancer specific mortality. And I think this was a 5-year period of time. And that using PET-CT prior to the diagnosis actually was associated with a higher likelihood of having stage-appropriate treatment, which I think makes sense. Sure. Right. So, and there's a figure here too as well that I think looks at just lung cancer diagnoses within the 5 years of diagnosis. Over time, they've kind of spread that out. So I think it's sort of interesting. I think we're using PET more and more, not just in this context, but in other contexts, certainly in infectious disease as well. But so it was kind of nice to be able to look at specifically sort of particular cancer and then also mortality and the potential benefit of that by using advanced imaging.
Yep. Yeah, and I found it interesting, and again, this is out of my wheelhouse clinically, and the invited commentary goes through, discusses some of the clinical situations and some of the other data and situates it really well. Basically, I think there's a couple of comments, like there's randomized and non-randomized data showing that patients with non-small cell lung cancer who get PET scans, generally, it does help guide therapy. There's also some interesting phrasing about how, clinicians seem to see the value, or it seems valuable while you're using it, which it's always tough with tests, because a lot of tests that it can seem helpful to use at the bedside, but isn't necessarily guiding treatment appropriately. But again, from with the amount of data we have and the way outcomes are going, it does seem interesting. And the potential, if this study were sitting by itself, you look at the figure and say, oh look, the mortality, the 5-year mortality is going down as the PET-CT is being used more, and does that just mean we're using it on healthier patients who are going to do better?
Right.
Which is unfortunately one of the things that we can do with advanced technology happens a lot. But apparently, situated in the other data, it seems like we're continuing to take better and better care of patients, which is always good.
It's always good, exactly.
Yep. So keeping in theme with lung cancer, but outside of the VA this time. The next paper looks at long-term survival of patients with early-stage non-small cell lung cancer, comparing surgery versus stereotactic body radiotherapy. They've got 104,000 patients in the National Cancer Database, about 91,000 who underwent surgery versus the remainder, the 13,000 who got stereotactic body radiotherapy. Of the surgery is about 80% lobectomy and 15% wedge resection. The rest got... or there were some who were getting a full pneumonectomies, which is, just a fun word to say.
Yeah.
And not surprisingly, those who didn't get surgery, who just got the radiotherapy, were more likely to be older or have lower clinical stages, other histology changes, confinement to lung 1, or only a single tumor nodule. They also looked at who was getting how many different lymph node examinations. Apparently, there's a lot of variation in when they do surgery, how many lymph nodes they look at, which is really interesting. And there's some variations in how patients did based on that. So it's interesting, but basically overall what they found is that in this observational data, the patients who got surgery did better. But again, that's generally the patients who didn't get surgery were older and probably less likely to be good candidates for surgery. But again, this is one piece of a much bigger puzzle. So this isn't, this isn't the only data, but it's certainly interesting here.
And was it just patients that had surgery, or was it also coupled with that regional lymph node examination? Or that was one piece of it?
Yeah, one piece of it. Yeah, and there was a couple more. There's a couple more granular things where, frankly, over my head on how many lymph nodes you looked at, and if you looked at too few, like the pneumonectomy patients, pneumonectomy was not associated with decreased mortality when they looked at no lymph nodes, or looked at more than 15 lymph nodes. So then it's kind of how arbitrary or non-arbitrary is it? Right, which to me, that kind of smells like it's more about what kind of patients are getting these procedures or what the procedures are doing to the patients. But again, this is, not, this isn't the care that I'm providing to patients, and I'm not going to pretend that I know all the data here. Right. That's still very kind of interesting, I think, to think about. Yeah, absolutely. So next up, we've got Juan who's joined us. Welcome. We're moving into our next paper in the table of contents. This is an interesting little paper where they did a mixed methods survey and qualitative study of contemporary views of research participant willingness to participate and share digital data in biomedical research. Basically, they had about 900 patients, and I think it was a Mechanical Turk survey, and they basically asked them, would you participate in this type of survey? It was funded by university, the federal government, or pharmaceutical company, and also would you share your social media data in the context of that surgery? And what's interesting but not terribly surprising is that patients were much more likely to participate if it was the survey was being done by a university. And you can see this in figure 2. And there's 2 bars because they did it at 2 different time periods. And the numbers basically dropped for the federal study sponsor or for a pharmaceutical company sponsor it. What's interesting is that less than half were willing to share social media data, which is really interesting. Again, the same kind of pattern, more likely to share with the university than federal than pharmaceutical. And what's always fascinating me about this stuff is social media data by its nature is shared. That's already data that you're basically, by you I mean me, are giving away for free to these big companies. But still people are reluctant to share that with the research sponsors. And
I actually wondered about this too, because more and more we're seeing, for example, people that are affiliated with the university are also having some funding from pharmaceutical, right? So I don't know. This doesn't really take that into account because it's a survey of what sort of the perception is. But I think we also don't realize exactly where data is going and who has it.
And, and these like you're saying, a lot of these lines aren't clean. And most university research is either federal or industry sponsored. There is some that's foundation sponsored that's a little different, but even then, it's still all this stuff is these lines aren't clean.
One thing I did want to mention was I was interested in this Mechanical Turk platform. I'd never heard of it before. It's kind of interesting. So it's basically a crowdsourcing marketplace. And you kind of can outsource. If you're doing some sort of data collection or cleaning or analysis, you can outsource that to a virtual platform.
My understanding is that it's owned and run by Amazon, and it's basically their way to get pretty big survey response survey samples without the same kind of infrastructure that you traditionally need to use. Also, the flip side, though, is the numbers that I see, like the whole idea is that you're supposed to get these big panels, but the numbers I see in the studies are just the same as every other survey. Like this was only 900. Like, that's not like, oh, wow, we use the power of the internet and found like hundreds of thousands of people. It's still like, I mean, maybe they can do it.
Survey fatigue, maybe.
Or maybe they're able to do it at much lower cost.
Oh, maybe.
Like that might be it, but it's still just I'm very, very far from an expert, but from how the idea was presented to me when I first heard about it to what I've seen about it since, it seems almost disappointing.
I think just getting, it's just hard to get people to answer surveys. It's tough. So more power to those that can do it.
And one last thing, that this was mixed methods, so they did some qualitative analysis, basically some interviews with some of the participants afterwards. And the main things that they found for why people said they wanted to participate in research, or the where basically the altruistic reasons, financial incentives, like you get $5 or something like that, or $50 for participating. And part of it was also trust or credibility to the sponsor, which really speaks to how the participants or potential participants view the sponsor of the study. Is it a university, the Fed, or a pharmaceutical company? So as a pretty much university employee, I appreciate a vote of confidence.
Yes.
All right, what's next?
So next we have, I'm getting all the really long titles today. It's good. Augmentation of positive valence system focused cognitive behavioral therapy by inaudible high frequency sounds for anhedonia. This is a trial protocol for a pilot study. So I'm going to give a little background because I needed to look up a little bit of background for myself. So we know anhedonia, it's an important symptom of depression, and it's often a treatment-resistant component of depression. And so there have been apparently some studies that have looked at the association of anhedonia with disturbances in what's known as the positive valence system. And so this is a system that's sort of responsible for our responses to positive motivational situations. And there have been other studies that have suggested that inaudible high-frequency sound therapy can enhance reward-related brain circuitry, which is sort of could potentially be part of this positive valence system. So the objective of this study will be to test sort of the effect of this inaudible high-frequency sound therapy on the efficacy of a positive valence system-focused cognitive behavioral therapy sort of experience to treat anhedonia specifically. So this is going to be a single center RCT. It's a superiority trial. It's based in Tokyo. They're aiming to get 44 patients for the intervention arm, which will include 8 weeks of this positive valence CBT therapy, plus the inaudible high frequency therapy versus placebo. So they actually have a placebo sound is my understanding, which I'm really interested as to what it is, but although I guess we wouldn't be able to tell because it's inaudible, right?
Well, and we've got the picture from eFigure 1 of what the regular speaker and the super tweeter, which I'm assuming is what you need to make high frequency sound.
Yeah.
And I don't know, I didn't read this in as much detail as you did, but I couldn't tell if the placebo is going to be just that the super tweeter's in the room, just not making noise, or there's going to be audible frequency.
Oh,
noise.
I thought it was the first thing.
Okay.
That's my understanding of it.
Okay.
But regardless, I think it's going to be really interesting. And the other thing that's sort of interesting about this is their primary outcome is actually going to be patient-reported anhedonia. And then the secondary outcome is actually going to be clinician-reported. So it's sort of a patient-facing study. So we'll look forward to seeing that. I think the trial ends, they're going to close up the final allocation in 2020. So soon to be determined.
So looking forward to it. And
yes.
again, I'm always supportive of research that includes super tweeters.
Yes, exactly.
All right. So next one, we got another survey study. This is interesting. It's perceived comparative harms of cigarettes and electronic nicotine delivery systems, or electronic vapes, basically. This is from the Tobacco Products and Risk Perception Surveys. It was done in 2017 through 2018 by Georgia State University Tobacco Center of Regulatory Science. They had 5,400 people in the survey in each of 2017 2018, and I don't think they used Mechanical Turk, so don't know how expensive it was. And basically, they were trying to show were people's views of cigarettes versus e-cigarettes changing, and there was a little bit of change. So basically, the fraction of people, of respondents who said that e-cigarettes were less harmful than traditional cigarettes was trending down from 29% to 26%. Those who said they're more harmful were trending up from 2.4 to 4.4%. And those who were saying that they're equally harmful went from 36 to 43%. So interesting. And what's most fascinating is this was well before any of the news about vape-associated lung injury.
Yeah.
So I bet those numbers have gotten much worse.
Absolutely.
And I don't know. I'm just going to go on a tirade for a little bit, but I don't think we know a lot about long-term harms of vaping yet. There's probably some potential benefit in getting people off traditional tobacco products onto vaping, but I'm really concerned at how these have been either implicitly or explicitly targeted at young people, and just we made big gains in getting young people to not smoke as much, and these are certainly as addictive, and I have a hard time believing they're not going to have similar long-term problems. So we don't data for that yet because the long-term hasn't happened yet.
No, exactly. And we talk a few weeks ago too about a similar topic. We were talking about the flavoring, right? And as a way to sort of market to these sort of younger generations. So
absolutely.
I think you're right. I think we will see. I think I think it's very interesting that this was before all of this sort of media. Although they do sort of posit that some of the negative sort of feelings towards electronic nicotine delivery systems may have been partly due to some negative media coverage already. So I agree. I think probably if we saw this today, it would be much different, much worse.
Yep, absolutely. All right, what's next?
Okay, so this is consistency of recommendations for evaluation and management of hypertension. And this is a study that was trying to examine how consistent clinical practice guidelines or recommendations for the management of hypertension really are with one another. Because, with a lot of diseases in general, we have all of these practice guidelines, but they don't always sort of square it with one another. So this is a cross-sectional study. They looked at clinical practice guidelines up to April of 2018. They used actually 3 raters independent raters to code the direction and strength of each recommendation, and then they compared with each other. So they ended up having 8 clinical practice guidelines looking at management of hypertension. They found that only 32% of these guidelines were actually consistent with one another for both strength and direction, which is really low, I thought, which just kind of points to the fact that a lot of these things that we think are straightforward are actually pretty confusing still. Right. And there's a lot of information that clinicians need to try to wade through to try to figure out what's best for the patient. We do have a figure here that looks just at sort of the different blood pressure thresholds across guidelines. You can see there's quite a variety too. There, and it was a very pretty figure too. I liked it.
Yeah, what's interesting? One of the things that's interesting to me about the figure is that apparently Hypertension Canada and then the NHS NICE guidelines don't count anything as normal or optimal blood pressure.
No, exactly.
There's only hypertension. There's no tension. And the other thing, is there's across these 8 clinical practice guidelines, they found 71 different recommendations to assess, and it's kind of. I'm not a primary care doc. This isn't chronic hypertension is not something that I manage a lot primarily. And at first, like, why are there so many? And then when they're looking at the things like the consistent ones, there are things like, it's like, how do you measure it? How many measurements do you need? Are there recommendations for things like lifestyle change? Other things there was good agreement on were ACE inhibitors and beta blockers in CHF and beta blockers in patients with recent MIs. Some of the stuff's like, and like. Some of that stuff I think is just so baked in. Yeah. It's like, of course there's 71 because 8 of these are, I'm making up that number, are how you just measure blood pressure.
Right.
Use the right size cuff. That's one of them.
Yeah. There's quite a variety, a spectrum, I guess I should say, for this. But I mean, even something, as prominent as hypertension, it's confusing, I think. Can be confusing.
Yep, absolutely. All right, so moving on. What's next? We've got NIH stuff.
Yes, okay. So this is co-author country affiliations and international collaborative research funded by U.S. National Institutes of Health, 2009 to 2017. This is a really interesting study. I think they were trying to look at the extent of, or quantify the extent of, the NIH's international collaborations through examining publications. And so another cross-sectional study, they looked at NIH-funded publications from 2009 to 2017 and then measured trends in the number of publications that were supported by the NIH that had international collaborators, co-investigators, or a primary investigator. And so if you look at figure 2B, actually, I really liked this one because this actually focuses on low to middle income countries. But overall, they found that the number of NIH-funded publications is going up 46%. Over this time period, and this is driven in part by actually the number or the percentage of publications with non-U.S. authors involved. So I think that they had said this went from 28% to 34.8% over this time period. It's a pretty short time period too, actually. And then if you look at figure 2b, as I was mentioning, looking just specifically at low to middle income countries, you see actually this trend is also going up. I mean, it's different depending on the country, but and Brazil actually, I like that. I see you.
Yeah, I didn't realize we did so much money with Brazil. I'm curious, is that, I think we do a lot of HIV research with Brazil, maybe?
We do, and there's also a lot of, there's vector-borne diseases as well, and I think there's been a lot of that, Zika, dengue, and yellow fever, all that has been coming out as well. The other thing that I kind of liked is that they also looked specifically at, this was sort of I think just a finding that, sort of like an exploratory thing that they found was that in 2017, publications with international collaborators actually had a higher mean citation impact compared to those with non-US authors alone, which is also kind of, I don't know, I liked it. I think this is, this question of making sure that global health collaborations that are occurring are really being inclusive of all the people that are involved in doing it is so important. And so it's nice to see that a light is being shined on this issue.
Yeah, absolutely. It's really interesting. Good to see that, we're continuing to do good research.
Yes.
And it's cited more and more. All right, I'm going to welcome Iyad Ohabi. Welcome. We're on our last paper in the table of contents for today. So this is an interesting one where they developed and validated a model for predicting the risk of acute kidney injury associated with contrast volume levels during PCI. So they looked at 2 million procedures from 2011 to 2015 in the National Cardiovascular Data Registry, CAT-PCI registry, and used the different cutoffs of AKI of an increase of creatinine of 0.3, 0.5, or 1. Obviously, lots of methodology stuff in there. They use a generalized additive model, or GAM, and basically found that it was about 6% of patients versus 3% of patients versus 1.4% of patients had those different levels of acute kidney injury. And they made these beautiful graphs.
Yeah.
Which I just, more than anything else, I just really like these. And basically the graph shows the contrast volume across the x-axis and the risk of AKI, basically, and what happened across those three cutoffs, and they're just beautiful, beautiful graphs. And you can see there's a pretty decent dose response to volume, the higher volumes. I've always been interested in one of the, for in my practice, I don't give arterial contrast to patients much. I certainly never do myself. I certainly send them to some patients to cath, or some patients for interventional procedures, especially things like stroke. But the we have to spend a lot of time talking about the risk of contrast-induced acute kidney injury for CAT scans is the big one.
Yeah, absolutely.
And one of the things that I've seen from the literature, or at least heard smart people talk about, is that the arterial contrast that's used in angiography has much higher rates of AKI. And looking at this, the volumes just seem to be much, much, much higher than the patients get from diagnostic scans. I'm curious how much it is arterial versus venous versus like the 125 milliliters they get for a CT scan, which I had to Google, versus, these patients getting up to like 800 milliliters or a liter of contrast, which just seems like a lot.
It does seem like a lot. I agree. I think one of the things that I will be interested in to see sort of down the road, and I think they mentioned this as a limitation, that they didn't have clinical information. They have this like pre-post kind of information to make the model, but to be able to predict the risk, but really seeing, are these changes clinically important, I think will be interesting. I would imagine if you're getting that much of a conscious load, there's definitely concern. We see it anecdotally all the time, but it will be interesting to see how this kind of progresses.
Yep. But even then, the risks here are pretty small. The risks are only up to about 1% or top out at 1% of this graph. And like you said, the clinical picture matters so much more. I remember one of the big studies a few years ago on post-contrast AKI for diagnostic patients in the ED and ICUs, and it was like, oh, look at this big increase in this composite metric of what happens to patients, and it was like, oh, none of it was mortality, none of it was renal replacement, it was all an increase of 0.5 in the creatinine, who went from on average 10.5 to 11 or something like that. Like, does that really matter?
No, who knows? We don't even know. It's not like we're taking our measurements throughout the day. And, when I don't drink enough water, I'm sure it's not pretty.
Yeah. So obviously, we want to do what's best for a patient, but sometimes, a lot of it's, again, it's a lot of the data we have that shows patients who are maybe at risk for contrast-induced nephropathy is just sick patients get contrast.
Yeah, absolutely.
So it's hard to know. But interesting stuff. Again, beautiful graphs. I always love beautiful graphs.
Definitely.
All right. Well, thank you so much for joining us today. We'll be back next week, Tuesday, 3 p.m. Central Time. Of course, see these papers and more at jamandnetworkopen.com. Everything is free, full text, and open access to use however you see fit. Follow us on the usual social media channels. And of course, if you are an American who celebrates, have a good Thanksgiving.
Happy Thanksgiving and holidays to everybody.
All right, take care.
Bye.